Today we're here with Dr. Carl Golnik visiting us here at Houston Methodist Hospital, so I thought I'd mix it up a little bit and ask Carl, who was our speaker last night at HOS, to talk a little bit about central retinal artery occlusion and transient monocular vision loss, amaurosis fugax. Carl, last night you told us a little bit about how there's a paradigm shift in the way we deal with these patients. Can you elaborate?
Sure. So I think that the real practical side of the thing is that in the past we thought that especially transient monocular vision loss, thought to be the ischemic form, the right age range, over 50, vascular risk factors, is not really that serious, and it was sort of dealt with in a fairly nonchalant manner, not thought to be an urgency, perhaps like a hemispheric TIA. And recently what we've come to believe, and what the guidelines say, is that it really is an emergency, and when you look at MRIs that are done at the time or near the time of the transient monocular vision loss or any other form of retinal ischemia, branch retinal artery occlusion, central retinal artery occlusion, you often will find silent strokes. So in actuality, these people are having strokes, as many even in the transient monocular visual loss, as many as a third are having silent strokes on MRI. And so of course the point is, like any stroke, you want to find it and try to make sure there are no subsequent strokes that might be devastating. So in fact, even transient monocular visual loss may be the harbinger of a lot worse to come. So the idea is to decrease morbidity and maybe mortality by finding it quickly. So we now think that transient monocular vision loss, VRAO, CRAO, are really emergencies, and these patients should be evaluated to make sure there's nothing else going on, and then sent to an emergency room, hopefully with a stroke team that will manage the patient and recommend the appropriate treatment based on their imaging.
So it's just a matter of timing then, Carl. So 2 hours in, go to the stroke service?
Yes.
2 days?
2 days, I would say yes.
2 weeks?
2 weeks is probably less acute, but I think I would probably not send them after 2 weeks acutely. I would order the scans on a more regular, semi-urgent basis.
2 months?
Same, 2 months.
Outpatient?
Yeah, outpatient.
2 years?
So 2 years ago, I translated lost vision. I probably would want to know what's transpired in the meantime, and what are their vascular risk factors? How are they being managed? Are they being managed? Have you seen a doctor? So I think that's going to be, of course, a much slower evaluation to evaluate all the risk factors. If nothing's happened in 2 years.
Normally I say 2 years and 2 decades, there's nothing wrong with you, or you have migraine as the cause of your vision loss.
If nothing has happened subsequently.
So for sure. Well, thanks, Carl, for participating in our YouTube.
Sure. Thank you.